All right, so now we're going to translate current and emerging therapies into enhanced management. This is really talk to folks on IL-17 and IL-23s. We know that people are very familiar with the TNF pathway, and so we're going to focus on the newer pathways now. I'm still the same person. I still have the same disclosures. And so, moderate severe psoriasis, really, what is it? I sort of got at this in the last talk. Essentially, it's people who have psoriasis that can't respond to topicals because it's too widespread, and/or it really impairs their health-related quality of life. And we're talking about at least 1.5 million people in the U.S., over 30 million people worldwide. And these folks, as I alluded to in the earlier talk, they have a higher risk of major cardiovascular events, diabetes and renal disease. They die about 5 years younger than they should based on their age-appropriate risk factors for mortality. And I tried to allude to that body surface area is not the only factor defining moderate severe psoriasis. So in my practice, I have plenty of patients who only have scalp psoriasis. Treating scalp psoriasis. So in my practice, I have plenty of patients who only have scalp psoriasis. Treating scalp psoriasis topically is misery for a lot of our patients and often ineffective, and is highly emotionally or physically burdensome for them. Genital psoriasis, of course, is highly burdensome for patients as well. And I have patients who have this isolated genital psoriasis that only affects their penis, and we still use biologics in that setting. And of course, palmoplantar disease, highly disabling. This is some recent data from my lab. So I mentioned earlier I do a lot of research in this area where we want to understand the prevalence of stigmatizing views in our population and what patients experience every day. And so when you survey people using like Amazon Turk, there's this general people out in the population, you ask them about psoriasis, show them some pictures of people with psoriasis, what you find is that nearly 40% said they would not want to shake hands with someone who has psoriasis. That's kind of a devastating finding if you think about that, because this is one of our most basic ways that we interact with each other in social environments. A third, and then when we asked them about endorsing stereotypes, roughly a third think psoriasis is contagious, affects only the skin, and it's not a serious disease. Okay? So you can imagine if you're a person with psoriasis trying to sort of work in society here, your disease is misunderstood, and there's a lack of empathy for patients dealing with this. And despite how tough the disease can be for people, there's still a lot of undertreatment. There's a recent analysis of claims data, so this is probably a best-case scenario. And where they estimated was that about 60% of people with moderate severe psoriasis weren't even treated in the previous year for their disease, 60%. This is an insured population, commercially insured population. Imagine if we're looking at the broader community out there. And those who were treated, about half of them lapsed on their treatment and weren't treated continuously. Well, you get the sense that what we really still have in our population is unfettered, ongoing chronic inflammation of the skin for these patients. Unfettered, ongoing chronic inflammation of the skin for these patients. How many of you here participate in the PQRS or MIPS program? Yeah, we got some hands. Okay, good. So we have an outcome-based measure we created a couple of years ago for psoriasis. It's the only dermatology outcome measure in MIPS, so we're proud of that. All of our other ones are process ones. And so our targets are having a global assessment less than or equal to 2, which is pretty easy. It's mild disease, not clear, almost clear. Or BSA less than 3%, or PASI less than 3. No one does a PASI. Or DLQI less than 5. That means you have mild to minimal impairment in quality of life. And we see in 2015 and 2017, we see an increasing number of people reporting and a decrease in their performance rate. You can just choose just one of these, by the way. So you say, I'm going to choose a global assessment. I'll let you know how many are achieving a global assessment of mild or less. And so roughly 60% performance rate in 2017 of meeting these quality metrics. We have a lot of room for improvement. Quality metrics. We have a lot of room for improvement. And we need to figure out ways to translate our improving therapies to leading to better outcomes for our patients. Let's talk a little bit about the pathophysiology of psoriasis. It's a disease of localized and systemic inflammation, epidermal hyperproliferation. I like to explain to patients that in psoriasis it takes about a month for a skin cell to turn over and be born. I'm sorry, in normal skin it's a month for it to turn over and be born. In psoriasis it's about a day or two. Okay? That impresses patients. They understand, well, this is why I'm so frickin' flaky, And I constantly, wake up, I get rid of my scales, and then 5 hours later, I'm full of scales again. It helps them understand what's going on. And then there's a lot of angiogenesis that's going on. You see these dilated capillary loops. The body needs to develop a lot of blood vessels to support all this epidermal turnover, and that's appreciated what's called the Auspit sign. The skin bleeds very easily. And again, patients, I think, often appreciate understanding what's going on with them. Like, why is it that my skin is bleeding on my blanket easily? And again, patients, I think, often appreciate understanding what's going on with them. Like, why is it that my skin is bleeding on my blankets? And we can explain this to them so you understand what's going on biologically. What's great about psoriasis and what's really fun studying this area and treating patients is that we have a good understanding of the immunopathogenesis that results in logical, targeted approaches. So the first thing I explain to the patients is on the left side, you see the triggers here, is that the keratinocytes and the melanocytes, cells in the skin, make peptides that the body gets confused by. The immune system reacts in an autoimmune manner to skin proteins that are completely normal. And I explain that if you think about it, this is how the body's idea was, is that if I had like an infection in my skin, this is how I'd fight it off. Let's flake it off. That was how we evolved. It was an evolutionary advantage to have this type of immune response. Of course, in modern day, it's not very advantageous for people, but it's not contagious. The skin is not infected. If anything, people with psoriasis have cleaner skin. It's upstream, and we have 4 TNF inhibitors approved for cutaneous disease. These are all approved for joint disease as well as other different inflammatory conditions. We have one drug that blocks IL-12 and 23, Ustekinumab. It's a P40 antibody drug. We have 2 drugs approved, a third about to be approved that target IL-23. We have 2 approved drugs that block IL-17A, Ixekizumab, Secukinumab, and a new one coming into phase 3, Bimekizumab, which blocks both IL-17A and IL-17F. I'm sure you're saying to yourself, who cares? What do you need to block F for? Well, I'm going to show you soon. Okay, stay tuned. That's a teaser. And then, if that wasn't enough for you, we have Adalimumab, which actually blocks the receptor itself, the IL-17 receptor itself. So in theory, you're blocking all sorts of subtypes of IL-17 when you use Adalimumab. And I think this is a very helpful diagram from my buddy Andy Blauvelt. Andy was at NIH many years, and then he went to OHSU. Now he's in a private setting in Oregon, does a lot of research in psoriasis. And what he's showing you is the different pathways of immunology and what you would predict based on downstream what infections you may be susceptible to. So, if you're looking at, say, a TNF pathway all the way over here, you're blocking all these pathways here, and that leads to susceptibility to all these types of infections, viral, atypical infections, mycobacteria, things of that nature. If you're looking at things that are more in the IL-17 pathway, it's fairly narrow all the way down here, and you're looking at Candida and Staph aureus. Candida clearly has been reproduced in the trials. People are more prone to yeast infections. Staph, which of course would be very worrisome, has not been clearly shown to be a risk of these drugs, although we have to keep looking for that. And the IL-12-20 biological therapy. Maybe immunosuppressive is a little bit of a strong word. I probably wouldn't use that with a patient. Immunomodulatory is a better word for patients. So as we talked about in the last section, I talked to people about being up to date on age-appropriate cancer screening. And this week I ordered a mammogram for my patient. I mean, she's a young woman. She's 40. She wants to be screened. She's got 2 young kids. She's a busy immigration attorney. So you can imagine how busy she is. She's an immigration attorney. So she's not going to get this done if she has to go to another doctor, get a prescription, and go someplace else. At Penn, she gets a prescription, goes downstairs, gets her mammo done, boom, it's done. Okay. Consider vaccinations for flu, pneumonia, shingles, potentially others. I usually try and give the flu shot to patients annually in my clinic, and we encourage shingles. We do TB screening at baseline, and I repeat it annually if there's risk factors. And I've had to have patients seroconvert over the years and develop active TB, usually with international travel. They have no risk factors. They go to Cuba, and they need to pick up TB in Cuba, things of that nature. They have no risk factors. They go to Cuba, and they need to pick up TB in Cuba, things of that nature. But my patients who are local, they really don't go very far outside of Philadelphia. They're not in places where they're exposed to TB. I stopped doing tuberculosis screening, counseling the patient that we're not going to do the annual screening so they're aware of this. Assess and treat infections aggressively. We often will hold the psoriasis drug. And there's a lot of nuances. The choice is often driven by insurance or cost issues. And so as a result, you can't just be like, you know what, I'm going to use TNFs, I'm done. Like, you really, if you can treat the disease, you have to know the whole armamentarium. Very quickly, at the 4 or 5 patients, you're going to run into a situation where you need to use a drug that maybe you weren't planning to use. So Ustekinumab is a P40 inhibitor, approved for psoriasis, psoriatic arthritis, inflammatory bowel disease at higher dosing, pediatric psoriasis. So nice to know what other diseases the drug's approved for, because occasionally I get in trouble with someone who has Crohn's. I'm like, oh. Its cousin, Mirikizumab, this one got halted for development in phase 3. It had safety signals for cancer, infection, and MACE. Okay? So this is a reminder that the antibody we're using and the dose of it matters. Okay? We haven't really had the same degree of signals in Ustekinumab that we saw in Mirikizumab, despite them having similar MOA. Okay, the IL-17 inhibitors, Secukinumab, this is approved for psoriasis, psoriatic arthritis, and ankylosing spondylitis. ICSI is up for psoriasis and psoriatic arthritis. Adalimumab is approved for psoriasis only currently. And then the IL-23 inhibitors, Guselkumab and Tildrakizumab, are both approved for psoriasis. Risankizumab should be approved any minute. I put my phone in sleep mode so it won't get disturbed, so someone can check their phone and see if it's been approved. It was approved in Europe, recently approved in Japan. And then Mirikizumab, the newest kid in the block, I'll show some phase 2 data. I put my phone in sleep mode so it won't get disturbed, so someone can check their phone and see if it's been approved. It was approved in Europe, recently approved in Japan. And then Mirikizumab, the newest kid in the block, I'll show some phase 2 data. All right, so I want to make sure we're on the same page about what a PASI endpoint is, what a PASI 75 is, a PASI 90 is. Because we need to understand what this means clinically for people. And so on the left side of your screen is a person at baseline. They have a PASI 25. And what that means, we're looking at how red, how scaly, and thick their patches are, and the overall amount of body surface area involved. And then at week 4, this person on a rapidly acting drug, they have they've achieved a PASI score of 5.9. They have more than a 75% reduction in PASI score. We call this a PASI 75. They don't have a 90% improvement, but they have more than a 75% improvement, a PASI 75. And you see this guy looks really good. I mean, his psoriasis looks much better than when he started off. And before the IL-23s and IL-17s came to market, this was the primary endpoint for all of our trials. Because this was like, if you could get this, that was like really good. And we were talking about maybe a PASI 50 was a good response also. I never really felt PASI 50 was clinically acceptable. But when we had less effective therapies, we were lowering the bar. If you're a rheumatologist, maybe you know the feeling, like you have an ACR 20. Who wants an ACR 20? You know, it's like not a lot of improvement. And a PASI 90 is now he is on the far right of your screen, and you can see he's pretty close to clear. He's clear or almost clear at this point in time. And you'll remember that back to my earlier slide, that question we asked, well, what percentage of people who are clear, almost clear, would meet subjective criteria for changing their therapy? And here's the data, the answer, if you will, so pay attention to this one. All right, so this is data we did as part of an NIH-funded study looking at the effectiveness of treatments in real-world clinical practice. Consecutive patients at many practices across the country just randomly coming in for their routine follow-up. You look at their skin, you do a PASI, they fill out a survey, and that's how we figure out what's going on. Nearly 20% of patients whose skin was only almost clear had moderate or more impairment in health-related quality of life. This was really surprising to me. Okay, I thought like most of these people, if they're almost clear, they're happy, I'm not going to do anything differently. But in fact, it's a big difference for patients to be clear. You know, that's really where they want to be. When their skin is clear, they have less worry that disease is going to come back, and fully experience the benefits of their therapy. So increasingly, we're hoping to get people completely clear. That's not always doable, but it's something we're trying to reach for our patients. We'll show some data now. So these are some of the phase 3 trials: Secukinumab versus Ustekinumab, looking at over 1 year time, which is great. At one point in time, at week 12, meaningful. It's not, actually. A year is getting closer. 2 years, 3 years, 4 years, 5 years. It'd be nicer to know long-term how the patients are doing, and we're getting there. And what you should know about the IL-17 is they work really fast. So by week 4, they have about 20 to 30% chance of having a PASI 90. Okay, that's pretty amazing if you think about that. And so when I use IL-17s, I like to bring the patient back early. I have them come in at week 4 because as a clinician, it's extremely gratifying to have a patient who's been living with the disease for 20 years and 4 weeks later, their skin is clear. I mean, it's like an amazing thing to behold, and I like to experience that with my patients. In this trial, at 1 year, it continued to have good efficacy, outperforming Ustekinumab, although the differences are fairly small. And Ustekinumab is a great option. So I wouldn't necessarily say that, oh, well, because of this, you have to use an IL-17 over Ustekinumab. Again, it gets back to patient preferences, comorbidities, things of that nature. All right, Ixekizumab versus Ustekinumab, same kind of story here. And look, by 4 weeks, nearly 55% of patients have a PASI 75. I mean, it's remarkable. This is Brodalumab, and recently a meta-analysis came out suggesting that Brodalumab, of all of our drugs, has the most rapid onset of efficacy. It's probably a smidge better than the other IL-17, so I don't think clinically it's a major thing, but certainly IL-17s work quick. If you have a person who comes in and like, Doc, I'm getting married in 3 weeks, what should I do? That's really your choice, is like, get them an IL-17. All right, and here they're showing it again to Ustekinumab, and again, rapid onset, high efficacy, beating an excellent drug. All right, so I talked a little bit about isolated psoriasis before, genital psoriasis, and this could be a devastating disease for people, and the problem the patients have is that their doctor's been thinking of them for years. We have localized disease, try these topicals and get out of my office. And the patients are really, devastated by this. They can't have normal, intimate relationships when they have psoriasis all over their genitals. The patients have is that their doctor's been thinking of them for years. We have localized disease, try these topicals and get out of my office. And the patients are really, devastated by this. They can't have normal, intimate relationships when they have psoriasis all over their genitals. And Lilly, to their credit, did a clinical trial of Ixekizumab, proving that it will do quite well for clearing genital psoriasis. So let's see if I can follow this. So the filled-in dots are clear, almost clear, and roughly 70% of patients are clear, almost clear, and about 40% of patients are completely clear. So that's pretty remarkable benefit for patients to consider. And I've done this in my practice several times. Personally, I've had more of a mixed bag of effectiveness on this, and I think a lot of that is because a lot of my patients are pre-treated with other things, because we're waiting for this data. They've been on TNFs, they've been on IL-17s, they've been on methotrexate, they've been on all sorts of stuff, and maybe they're getting more and more treatment resistant. All right, so I mentioned, what the F? Why the F on IL-17, right? They have this on a tape delay, Joe, so don't worry. They could beep anything out. They'll take it out. This is unbelievable. So this is phase 2 data, so it's a small sample size. But at week, let's see if I can read this. At week 12, 60% of patients were 100% clear. At week 12, think about it. I mean, that's amazing efficacy. So that gives us some data that blocking IL-17F is important, probably, in addition to blocking IL-17A. Patients are a little more prone to candidal or yeast infections, as we expect, based on the data I showed you earlier, based on MOA. Small trial, I won't get into safety, because there's not enough data here to really think about safety. Let's see what we learn in the phase 3 program. All right, Guselkumab versus Adalimumab. So this is a phase 3 trial, but they actually did this in phase 2, which I think is pretty gutsy. I don't know why you would do it. And again, Adalimumab is an excellent drug, and an IL-23 does much better, as you see. And again, looking at 48-week endpoint, you see some efficacy tapering off over time for those red squares. It's Adalimumab, with the triangles tend to do better over time with the 23s. And the other thing I'll notice is that you'll see, like at week 12, they still get some extra benefit if you keep on going. The 23s, they work well, they work fairly quickly, but they also, their peak benefit tends to be a little bit later. So if you have a really tough patient, really stubborn disease at week 12, week 16, and they're not fully where you want them to be, I usually want to wait to week 24, maybe a little bit longer, before I decide I'm going to pull off from trying to use that mechanism. This is a clinically helpful piece of information. I got a patient in my clinic. They've been on Ustekinumab for 5 years. They've been doing well, but every time they come in, they're like, Doc, we completely clear. So what do I do in this circumstance? Can I use an IL-23? And that essentially is what this trial asked. Everyone got Ustekinumab on label, and then if they weren't responding well, they got randomized to Guselkumab or Ustekinumab. And what you can see from the plots in these graphs is that the green dots are people getting Guselkumab, a targeted IL-23, that they do better than those who continue on Ustekinumab over time, have a higher odds of getting clear, almost clear, and all of our other metrics that we have available to us here. and it's a fairly sustainable response. So this is really important information from a biological point of view, right? Because what it's told us is that at the time, people thought IL-12 was important to psoriasis pathophysiology. This in humans is now telling us it probably is not, right? Because a drug that blocks 23 does better than a drug that blocks 23 and 12. And then the most recent kid in the block in the 23 club, Tildrakizumab versus Etanercept. Anyone want to postulate why they compare it to Etanercept as opposed to? Okay, I won't put people on the spot here, but you'll see in a minute. So, but it works well, and it's FDA approved. All right. Well, I'm going backwards now, which is. I hope I didn't press the wrong button. Okay, so here's some Risankizumab data, kind of a boring table. This is from the Lancet. But again, this is the newest IL-23, which will come out pretty soon, any minute, if anyone's refreshed. Is Len tweeting about it? Follow Len's Twitter and see if he said anything about it. All right. So here what we see is at week 16, 37% clear are clear. And at week 52, nearly 60% are clear. I mean, that's amazing, right? Nearly 60% with complicated inflammatory disease at a year, 60% of people are pretty much clear. And again, recapitulates what I mentioned to you earlier, which is that be a little patient with these drugs. I mean, that's amazing, right? Nearly 60% with complicated inflammatory disease at a year, 60% of people are pretty much clear. And again, recapitulates what I mentioned to you earlier, which is that be a little patient with these drugs. You know, they're not all the way there at week 12 or week 24. Consider sticking in it a little bit longer to see where you go, because there seems to be some cumulative benefit over time. All right, and so this is an eye chart. Those in the back of the room, if you could just tell me which line you're able to see. We don't have ophthalmology in our group yet, but I thought I'd. We have one for uveitis, something like that. I want to throw something in there for the eye docs. All right. What they're basically, so it's an IL-23 inhibitor, phase 2 data, and what they're basically showing is that roughly 60% of patients dosed every 8 weeks get a PASI 90. So it's pretty darn good. It's pretty close to Guselkumab, and I'll show you that. Missions, as think about what is our treatment approach going to be. You know, I have an armamentarium. I have a myriad of topical medications and vehicles. I have oral medications. I have phototherapeutic modalities, and I have multiple different classes of biologics, and within class, multiple different ones to choose from. Actually, that should be say TNF4. I did not get updated somehow. We have 4 TNFs approved for psoriasis. So the way I talk about my patients when I know they need something more in topicals, I explain we have ultraviolet light treatments, we have pills, we have injectable medications. And based on what I already know about the patient, what I understand about their preferences and their comorbidities, I'm already thinking about how I want to steer the conversation to where I think they can be best served. And at the end of that discussion, the question is, well, you know, how do you feel about this discussion? What would you like to do? And we have an electronic portal. Oftentimes I say, we don't have to decide right this second. You can go home, we'll get your blood work done, screen things, make sure things are good, and we can decide which direction you want to go. And then after the things, make sure things are good, and we can decide which direction you want to go. And then after this very cogent and, dare I say, brilliant analysis of the appropriate therapy for the patient, I put in an electronic prescription to my pharmacy, and then I'm told I have to use something else by the HMO, wherever it is. So, and then we restart the conversation all over again. But such is the way current medical practice is. These are here for summary charts for you. It's a lot to keep straight in your head. I mean, I live, breathe, and think psoriasis all the time. I have a huge research program in psoriasis. I see mainly psoriasis patients. So for me, this is like the back of my hand, but it's hard to keep it straight. So this is looking at the dosing regimens for our various classes of drugs. So, you know, for TNFs, you have regimens that go from weekly to every 2 weeks to monthly to every 8 weeks. It's important to recognize if you're a rheumatologist, a lot of times the dosing of our drugs is higher than when you're using it for joint disease. So the dosing of Tildrakizumab is generally double, 400 milligrams we offer people every 2 weeks, which is twice what you would do in psoriatic arthritis, for example. Then Ustekinumab is every 12-week drug, Guselkumab every 8-week, Tildrakizumab every 12, so a little bit of advantage there. Risankizumab, when that comes out, will likely be I'm sure will be every 12. Efficacy and Secukinumab are every 4 weeks with a big loading dose in the beginning, and then Adalimumab is every 2 weeks. And there's a lot of patients out there we just find in practice who just need constant drug that you can't dose them every month. And so an every 2-week option is nice, or sometimes with Secukinumab, you can dose them, this would be off-label, but instead of giving them 250 milligram injections once a month, I do 1 every 2 weeks. And for some patients, that helps them have better control of their disease throughout time. All right, so then you need to be aware of the important biologically driven adverse events. And the good news is that most of these things are uncommon. Like the things we really worry about are fairly uncommon, unlikely to affect your patient. And if you're not treating a lot of patients, you'll probably never see it because you really need to treat probably a few hundred patients to pick these things up because they're uncommon. The TNFs have much busier prescribing information. Some of that's based on the fact that others have done. But you need to know that they can be prone to serious infections, malignancies, demyelinization, aggravation of congestive heart failure, and that it carries black box warnings. So when we're counseling, the patient has to be aware of this. You don't want them to be surprised when they get home and they Google it, and you're like, oh yeah, this is completely safe, go take it, and you can take it even if you're pregnant, and they read this stuff and they feel like that you don't either know what you're doing or you don't care to tell them what's happening. All right, then the 23s and the 17s. So these have currently easier labeling. Some of that is driven by the fact they do seem rather safe. A lot of it's also driven by the fact that they usually use as monotherapy. They're not being studied intensively yet with a lot of prednisone and azathioprine and things of that nature. So we don't really know as much about what happens when you start using it in other scenarios. But basically, Ustekinumab, because it has an IL-12 effect, the FDA thinks theoretically it could increase the risk of malignancy. There really hasn't been much data to prove that. But basically, Ustekinumab, because it has an IL-12 effect, the FDA thinks theoretically it could increase the risk of malignancy. There really hasn't been much data to prove that. The observational data is pretty reassuring to date. And then there's this one bizarre case of reversible posterior leukoencephalopathy that occurred in the program, and therefore people are convinced that whenever they have a headache, that they have some type of neurologic problem from the drug, but it's really has not been seen much. So the patient has to be counseled about that. But then the IL-23s, Guselkumab, Tildrakizumab, their main things is warnings around serious infections that are quite uncommon. That's the main thing we counsel them about. The IL-17s, they need to be counseled about infections, of course. They need to be counseled about yeast infections. And so people who already have, like women who say I have problems with yeast infections regularly, I would steer away from IL-17. There's no need to push that issue if they have other options available to them. But usually it's easily managed. In some cases, people could develop a esophageal candidiasis for that. This is people often misdiagnosed and havoc ensues, right? They're having a heart attack, they have cancer, all these terrible things. They just need a little nystatin switch and swallow and it goes away, a little diflucan. Usually that's heartburn that doesn't get better with standard treatment of heartburn, and often they may have some oral pharyngeal thrush going on. They also have a warning for inflammatory bowel disease, exacerbation of or initiation of. And so like the patient I talked about earlier, people have a strong family history of Crohn's disease. It's a very emotional situation for them. They have a genetic load. They may be more likely to develop Crohn's. And having practiced now for about 20 years, I have at least 4 or 5 patients who are on TNF inhibitors and came off them for whatever reason and developed ulcerative colitis fairly rapidly thereafter. And then the debate is, well, did the TNF inhibitor, no one thinks TNF inhibitor caused that ulcerative colitis. The thinking is, oh, well, you were preventing it the whole time, which who knows if that's true or not. But you were preventing it the whole time, which who knows if that's true or not. But obviously, if you're using a drug that has a warning for it and they develop it, there's going to be more concern amongst the patients. So you got to counsel them carefully, and I then monitor them for the symptoms when they come up and follow up. And then Adalimumab had a safety signal in its phase 3 program. There was an imbalance in the number of suicidal events in those getting the drug versus placebo. There wasn't much of a correlation between the duration of being on the drug. A lot of these people had heavy risk factors. There were some clusterings at one of the sites, and for those who know suicidal epidemiology, it's not uncommon that you have one suicide, there will be others in the community that then go along with it. It's a sort of a tragic situation. So, the causality is clearly not known. Many of us think it's sort of a false signal, but we're stuck with it having a black box warning. There's a REMS program the patient has to register for. So if they weren't anxious and depressed before you started this medication, I guarantee you they will be. Odds of having a PASI 90 at the primary endpoint, week 12 or week 16, depending on the trial. The blue bar is what the background placebo rate was. And you can see, the drugs really distinguish themselves when you set a high bar. So, Apremilast, about 9% of patients hit a PASI 90. So the odds of your patient getting clear on that drug's pretty low when it comes down to it. You got to treat a lot of people to get that kind of good response. Adalimumab, an excellent drug, you're looking around 45% probability of getting there, similar to Ustekinumab. Then when we get to the IL-17s and Broda and ICSI, it goes up. So Secukinumab is around 57%, Broda and ICSI are higher, 70%. Guselkumab, Risankizumab in the 73 to 75%. You remember I showed you Bimekizumab data. That data bears out that was 80%. We're clear, 100% clear, right? So, no, I'm sorry, it's PASI 90. So we may even achieve higher than we currently have. And then Tildra and IL-23, we're clear, 100% clear, right? So, no, I'm sorry, it's PASI 90. So we may even achieve higher than we currently have. And then Tildra and IL-23, 37% probability of getting PASI 90 at primary endpoint. So it tells you, again, that the antibody you use matters. You can't just say, I'm just going to do a 23, they're all the same. They all have their nuances in terms of dosing frequency and outcome. The other thing I have to be aware of is that in the real world, people tend to not respond as well as we would predict based on clinical trials data. So on the left side of your screen is data from my network. This is now getting older data because we don't have the newer biologics on it. But the histogram shows their odds of being clear, almost clear in the day they show up in practice on their therapy. The horizontal bar is what they should have been based on the clinical trial data. So you can see for Adalimumab, about 65% should have been clear, almost clear, and we're really around 42% or something like that, 48%. And the story is worse if people were obese, multiple biologics in the past, things of that nature. And then the second thing to think about is what we call cumulative drug survival of our therapies. So as a general rule, the biologics tend to lose response over time at different rates. Some of that we think may be related to development of drug-neutralizing antibodies, but a lot of it's probably not that. It's probably other pharmacodynamic processes that we don't fully understand. Now, this is sort of new data that comes out of Denmark. Generally speaking, the studies consistently show that Ustekinumab does the best for long-term drug survival. These data suggest that Secukinumab is not doing as well as we would have predicted, but it's small data. It's only a handful of patients, I think 20 to 40 or something like that. Even looking at naive patients had the same problem. I'll say in my own practice, I've had patients lose response to that therapy over time, but again, they tend to be fairly treatment-resistant people. And if you think about Biologic, what's going on is I'm starting them off, giving them 300 milligrams weekly for 5 weeks, and then 6 months later, they're coming down to a different steady state. So for some of my patients, Secukinumab, they're losing response. I could often regain response by reloading them and then hiding out from the insurance company for a little bit, because it's an expensive way to manage this disease. I'm just going to close with some recommendations from the AAD guidelines, which are coming out now. They're available online, and I was a part of this robust group. And they're really dense. They're like, they must be, 1,050 pages. It's even longer. I don't even know. Anyway, so, but I'll have some pearls for you, and as a clinician, it's helpful to know, where is their data that you're going to go to an insurance company and say, well, this is why I'm doing this, is why you should cover it, okay? So for Etanercept, there's data showing that in adults with moderate severe psoriasis affecting the scalp or nails, it's effective for the scalp and the nails. So someone has nail disease or scalp disease, you use as monotherapy. Infliximab, we have data showing you use it as a shorter interval and going up to 10 milligrams per kilogram. That's really helpful because we know there's higher risk of side effects with higher dosing, and so it's nice to know there's data that we recommend 40 mg once a week for better control in some patients. We often have to do that in clinical practice. You now have level A data to justify that. And then monotherapy, people with just psoriasis affecting the palms and soles or just affecting the nails. Now, plenty of people who just have isolated nail disease and I have level A data to suggest that I could use this, and I do. And I will say, I did have one primary care doctor once tell the patient, was I crazy to treat her nail disease with a biologic? Now, I don't want to unpack that question, but I will say that, that from an evidence-based medicine point of view, I was not crazy, right? And her nails cleared to do quite well. All right, then let's talk about the IL-12, 23s, 17s, and 23s. So Ustekinumab, we recommend alternative dosages in people who are, if people are less than 100 kilos, we recommend dosing at 90 milligrams if necessary or every 8 weeks, because we know a lot of people need every 8-week dosing. That's what clinical practice has taught us, and trials have backed that up. Secukinumab is recommended level A evidence for people with psoriasis affecting nails or palmoplantar plaque psoriasis. The pustular variant, it seems beneficial, but it didn't really meet its primary endpoint. Palmoplantar pustular disease is very hard to treat. All right, and then Guselkumab recommended for monotherapy in people with scalp, nail, plaque-type palmoplantar psoriasis. Okay, so when you get the epic in-basket message from the GP saying, are you nuts, why are you using a biologic for this person? They only have it in a small amount of body. You're like, I have level A evidence that this is an appropriate thing to do. And it also works for the insurance company sometimes. And then this is meant to be a summary chart. You know, I don't know if any of you watch Plinko from this game called The Price is Right. Bob Barker. Yeah. Bob Barker's the host, right? The way it would work is you would take a chip, you'd put it at the top, it would bounce around, good music, and then it would get to the bottom. I'm going to get myself in trouble. They're going to turn off my microphone in a second. All right, it would get to the bottom, and then either you've got nothing or you want a jackpot, good things happen. And that often is how it feels in clinical practice. You know, we don't have personalized medicine to the extent that we could say, this is your genetic phenotype, this is the drug you should use. And so to me, I think about their comorbidities, their preferences, and that's how I try and target which therapy I'm going to use. So, you know, the patient is on the nervous side, they want long-term data. You know, TNFs, we have more than 20 years experience. I mean, I have some patients on TNF inhibitors from the original trials back in the late 90s. Psoriatic arthritis, according to the ACR guidelines, they view TNFs as the gold standard. I personally believe that IL-17s are probably a very good option for these people as well. The IL-12/23s are approved, but not generally figured to be as beneficial, and we'll see what happens with the 23s. They have Crohn's disease or fear of Crohn's disease. Well, we have Adalimumab, Tildrakizumab, Infliximab, all options for these people as well. The IL-12/23s are approved, but not generally figured to be as beneficial, and we'll see what happens with the 23s. They have Crohn's disease or fear of Crohn's disease. Well, we have Adalimumab, Tildrakizumab, Infliximab, all approved for skin and bowel disease, as is Ustekinumab at higher dosing. And there's a warning for IL-17. Len talked a little about issues of cardiovascular risk in people, and we know there's lots of observational data that TNF inhibitors seem to lower the risk of cardiovascular events over time. If you like this talk, stay till Sunday. I'm going to really dissect that data in great detail about whether or not we think that's a causal effect or not. But we don't have that data for the other drugs. It's emerging. They have a background of congestive heart failure. We usually stick away from the TNFs. They have multiple sclerosis, and again, you got to ask specifically. So, I'd say, ever had any medical problems? No. Ever had multiple sclerosis? No. Ever had demyelinization or Guillain-Barré? No. Ever had optic neuritis program going forward there with a more avid antibody? The 12/23s had no effect, no harm, no benefit in trials. Ease of administration, you really need 12/23 or 23 range there. If they're obese, you want higher efficacy drugs. If you need rapid onset, you're looking at IL-17s. If you're looking to win the game over the long haul, you're a marathon runner as a clinician, probably the 23 pathway. So much. I'm all over time, so I won't take questions, but I'll be around throughout the weekend. And welcome to the IIS. Welcome back for those who have been here before. And I hope you